So we are actually blessed with two speakers for our first presentation of the day, both of whom practice here in Portland at OHSU. Dr. Jeffrey Robinson is an assistant professor of medicine in the Division of Pulmonary and Critical Care Medicine. His academic interests include advancing the care of pulmonary hypertension through clinical trials. Clinically, his main interests are the care of patients with pulmonary hypertension and autoimmune-related lung disease. Joining him today is Dr. Daniel Seifer, who is also an assistant professor of medicine at the Division of Pulmonary and Critical Care Medicine at OHSU. He has particular interests in immunology, physiology, operational efficiency, the integration of technology into clinical practice, and in promoting and practicing a humanistic approach to medicine. They are here today to discuss lung involvement in scleroderma. Please join me in giving a warm welcome to Dr. Jeffrey Robinson and Dr. Daniel Seifer. Good morning, doctors.
Good morning, everybody, and thank you for having us. Let us deal with the technical aspects of taking control of this and sharing our screens, and then we'll get going.
Just making you co-hosts here. That's Dr. Robinson. There he is.
Okay. Does that look like something that everybody can see?
I see it.
Okay,
yeah.
Excellent. Well, then I'll get started. It's really, like I said, a pleasure to get the chance to speak with y'all. I won't double do my introduction since it's already been done so well, so thank you for that. I'll be speaking at the beginning of this about interstitial lung damage and helping to sort of clarify and define some of those terms, and then my colleague, Dr. Jeff Robinson, is going to be following us. I think just to share what the unified thrust of our approach is going to be here, we want to share how we approach caring for patients who have sustained tissue damage from their immune systems. And that, of course, is a group of things called autoimmune disease. And of course, in particular, we're going to be focusing on the autoimmune disease scleroderma, although as many of you have personal experience with, it's worth remembering that oftentimes there is significant overlap between the names of these conditions. And most of what we're going to share is going to broadly apply to this entire group. Following up on that, let's get started by doing some of the clarification work, because that's going to be a decent amount of this beginning. It can be easy to misinterpret the words associated with these issues, of course, if one hasn't encountered them before. Scleroderma as a term is a clinical term, and it covers both localized conditions in which the autoimmune disease or the person's immune system may affect one target, such as the skin. So that would be on this slide over here, localized linear morphia. And the more potentially dangerous generalized conditions in which multiple organs are under attack. The blue box on this slide is what's showing that generalized scleroderma, systemic sclerosis, SSC, CREST, these are all really equivalent terms. And there are subtypes of this, subtypes that are defined by saying words like limited, diffuse, systemic sclerosis, and scleroderma, but those things don't refer to the involvement of multiple organs. They actually all share that. So in this sense, limited, diffuse, these things, limited does not mean mild and diffuse does not mean severe. They're referring to the extent of skin involvement, okay? Unsurprisingly, it's these patients, these ones with generalized issues, that we're going to be focusing on today, since they're the ones who can develop lung and heart damage, because those are two of the organ sets that are affected. And this focus really isn't unwarranted, as many of you know, because it is the lung damage and the pulmonary hypertension, which is a type of vascular heart-related damage, that are the leading causes of death in patients with generalized scleroderma. Right? So it's worth focusing on the edges where most of the damage is caused, where potentially the most mortality is, and then working one's way back in. And these are not small percentages. 35% of all SCC-related deaths are due to interstitial lung damage and 26% related to pulmonary arterial hypertension. And as you'll see throughout this talk, there is significant overlap between those. Now, I mentioned Dr. Robinson's going to be speaking about the pulmonary arterial hypertension and getting into that in the latter half of this talk. And I'm going to focus on the interstitial lung portions of things. And in order to start there, and I think that I've seen many familiar faces here in the audience, people that I've actually met clinically one way or another. So this may be review. But But I want to make sure that everybody gets to hear this, because these are things that I think even trip up many physicians, pulmonary physicians that end up caring for patients like yourselves, which is sort this word salad out. Because if one could go back 40 or 50 years and rename some of these things, I think we would save ourselves a lot of trouble. But in lieu of being able to do that, I think we have to clarify what it is that we mean when we say certain things. So in this case, pulmonary fibrosis, that literally is just a term that means lung scarring. It is not the name of a disease at all. It's literally just a description of the tissue changes that are happening. There are hundreds of potential causes of this, many of which have nothing to do with the immune system. Now, ILD, or interstitial lung disease, and you also see a slash mark here where I've defined the interstitial lung damage. Different people will use the ILD to mean both sides of this. This is one of the possible causes of pulmonary fibrosis. It's not the only thing, but it's one of the possible causes of lung scarring. And this is also an incredibly broad category. The interstitium of the lung, which we'll show in a few slides here, it's a part of your body. It's like saying your skin or your eye. And so if one were to say skin disease or eye disease, that's pretty clear, right? That's a really broad category, as is this. There are a lot of different things that can affect this part of your body, the interstitium of your lung. And the distinction between something, at least this is how I break it down for clarity of thought purposes, the distinction between something that's an interstitial lung disease versus something that's interstitial lung damage. Interstitial lung disease is something that's really only focused in the lung, and the entirety of that disease is subsumed by the lung. It's there, only there. And interstitial lung damage is a situation in which you may have something going on throughout your entire body that's causing disease to the lung, causing damage to the lung. Now, why do we care in this particular case if this part of the body takes damage? Why is it so scary? Why is it so potentially fatal? What we have here is a bigger, smaller, and smallest slices of a piece of art that shows us different pieces of the lung. What we have here in the center is the trachea, which brings down the air into your lung, which is one of both sides. So it branches off and kind of looks like a beautiful upside down tree. So that's one of the major parts of your lung, is the things that move the air down there. The other major part of your lung are the blood vessels that run throughout that webbing and circle around these areas where the air gets to at the end that looks like little balloons. And the reason for this, right, is that the main job of your lung is to take something that's in the air, in this case oxygen, and exchange it with something that's in your blood, which is carbon dioxide. It has to let those two things pass. And there's not a little creature or a little machine down there that moves one to the other. It's actually a process called diffusion, in which things have to these gases have to pass through a part of your body. And that part of the body is what's in between the air and the blood vessels. And that's what interstitium means. It's the part that's in between. So when we talk about the interstitial part of your lung, we're talking about the part that's between the air carrying parts and the blood vessels. Yeah. And what's the problem? Why this is potentially fatal is when that part of the body takes damage, and eventually, if it does turn into scar because of that damage, it can't do its job anymore. Yeah, those gases can't pass through that wall. It's too thick now. Okay, so moving on back to more of this word salad now that we've got a little bit of a picture in our head. Let's take a step forward though and discuss some of the causes. I know this isn't, as you'll see, necessarily relevant, but because these terms get thrown around, I want to make sure that we re-emphasize that this is something separate. So an example of an interstitial lung disease, a disease that is limited to the lung, is defined by its involvement and damage to the lung, and that can end up with lung scarring, would be idiopathic pulmonary fibrosis, IPF, which literally means lung scarring, and we don't know why. Most people would define this as a disease. In fact, it's probably a group of diseases, because when you define something by what it's not, that's not usually a good answer, right? If you defined an orange by saying, well, it's not an apple, that's a very broad category, and there's a lot of things that would fit into the not an apple category, right? You really have to, it's much more useful to get down to positive definitions of something that describes the problem itself, but we're not quite there yet with this condition, hence lung scarring, and we don't know why. This is not what is happening with scleroderma. And while there are some shared features, they involve lung scarring, Many of the same words like pulmonary fibrosis are thrown around. They affect the same part of the body. They are not the same condition. There are fundamental differences that are very important. In scleroderma and other types of autoimmune disease, what we're dealing with is there's a systemic problem, right? There's an issue with your immune cells, your immune systems. It's attacking your own body, it's attacking multiple organ systems, and that is causing interstitial lung damage. So again, in the way that I split this up, it's not so much an interstitial lung disease as it is interstitial lung damage that's being caused by a systemic problem. And if that damage continues to happen, it does lead to lung scarring, which is also called pulmonary fibrosis. Yeah. So the fundamental difference here is that we know the source of this lung damage. We know it. The body's immune system has a system-wide problem, and it's causing damage to this part of the body. So maybe asking, okay, what does all this matter? Right? It's great to sit up here and talk about these things like we're some sort of human dictionary, but why does this matter? Well, it is the only thing that matters in a way, because it's easier to stop damage once you know the cause. With something like scarring and you don't know why, you can imagine there's a lot of flailing around out there because you don't actually know what to stand in the way of. But with scleroderma, we actually know a lot more about it. Yeah. And I've got a little diagram which can be a little silly, but sometimes I think, especially in the morning, it can be useful to be a little bit silly as long as you're sticking with a line of truth underneath it, right? And this is to help everyone here without like looking at diagrams of cells and a bunch of Latin named receptors, to understand what's actually going on, because tissue damage is not like a light switch. It's not as if your tissue is either happy or sad, right? There's a continuum. It's a much better way of thinking about it is actually this diagram in which there's a really, really heavy boulder on the top of a hill, and there's a bump here at the top of the hill, right? So if there's a bump in the way of a heavy boulder, it would take quite a bit to push it over that bump. But once you got the heavy boulder over that bump, right, it's going to start rolling. Gravity is going to pull this thing, and it's going to accelerate down the hill, and it's going to get up some pretty significant speed. And in this particular diagram, what's at the bottom of this hill would be lung scarring. Okay. So for instance, right, if you took tissue damage, for instance, you cut your finger, yeah, and then you took great care of it afterwards. You covered it, put a Band-Aid on it, kept it clean, right? That little nudge of damage is not enough to push the tissue into rolling down this hill towards scar. Yeah. And if it doesn't go start rolling down this hill towards scar, that tissue will eventually heal. And you may not actually have anything. You may not even know 4 months later, or for those of us that are creeping up there in age, more like 6 to 8 months later, you may not even know that there was a cut on your finger. But what if you cut your finger and then you cut it again and you pour some lemon juice in there, and you don't want to put a Band-Aid on there because it's gardening season, and you go out there and you garden and you keep doing these things over and over again to it. Eventually your body throws up its hands and says, no more, okay, forget this. I'm just going to turn into scar. You refuse to take care of this. It's scar time, right? And that's symbolized in this diagram by pushing into the bump. Now we've got 3 hapless little assistants here, right, to help us with where we're going with this analogy. And what I want to talk about, and the reason that I'm putting these people here, is that if you, and this is what you and us are together trying to do in the case of damaged tissue, is we're trying to stop that tissue damage, right? We would like this tissue damage not to occur. When we're talking about cutting our finger, that's easy, you know, wear some cut-proof gloves or just avoid your fingers. But with something like scleroderma or other types of tissue damage that are inside our bodies, what we're trying to do is stop it. Yeah. You can imagine, though, if you had to pick which one of these people you wanted to be to push against this boulder, you would not want to be the person at the bottom, right? That's not going to end well. Sure, you may be able to slow the boulder down a little bit. It may be going 10 miles per hour before it flattens you and 9 miles per hour after that. But I wouldn't call that a success. That might be the best you can do if you were trying to do something, but it's not great. And similarly, this person in the middle, right? This is a pretty big boulder. By the time it reaches the middle of this hill, whew, you may need an army there if you're really going to slow it down, much less push it back up, right? Now, you're in a much better situation if you start pushing before it gets over the hump. You're actually working with gravity a little bit there, right? Because the source of damage is trying to push it up and over this hump to get it rolling down, but you would be forcing it back, yeah? But that's still not the best. That's still not the best you can possibly end up with here, right? The best, the absolute best would be to get to the problem before it starts pushing. Why fight with something if you can just shut it down? Yeah, if you can shut it down entirely, then there's nothing pushing on that side of tissue. There's nothing that's going to be damaging the tissue in the first place. There's nothing that you have to worry about pushing a rock down a hill for. Yeah. So these are the differences. Yeah, these are the differences between knowing a cause and not knowing a cause. In the case where lung scarring and we don't know why, which again, fundamentally different from scleroderma, we're really having to stand down here. We don't know what's up here, so we can't mess with it. But in scleroderma, we do know what's up here. We know about what the source of the damage is. Yeah. And so affecting that is a different issue than standing at the bottom of the hill. So what do we want to do about this? We want to find it early and again, treat the root cause. Unfortunately, or maybe fortunately, because we know this piece already, we can't rely on symptoms to do this. We can't, if a physician is saying, well, we don't actually need to worry about this. I know that we have, you have scleroderma or you have some features associated with it, but your breathing is fine. You're doing just fine. We don't need to worry about this. That's not sufficient. That's not even close to sufficient. Yeah. So lungs and many other parts of our bodies are kind of like babies. Babies cry, and that can mean a lot of different things, right? It can mean they're hungry, it can mean they're just not happy, they don't like your music, it's that time of day, you name it, right? So there's only so many things that your lung can actually cause a symptom of to get your attention. And one of those things is shortness of breath. Another one of those is cough. But hundreds of things can cause those symptoms. They're not specific. And to complicate things even further, early lung damage, early damage to the interstitium of the lung is most of the time without any symptoms at all. Yeah. So because of this, just because you have no symptoms doesn't mean you are free of lung damage. And just because you have symptoms doesn't mean you actually have this type of lung damage. So symptoms, while we want to know about them because we want to treat them and help them, they're not crucial to sort of figuring out if this part of the lung has been damaged or not, and whether or not we have to treat it. What is crucial is looking at this part of the lung. Chest x-rays are not good enough. I don't like to beat around the bush, so I'm not going to take a lot. They're not good enough. They're very good at seeing certain things, and they can certainly see severe damage of certain types, but they are not anywhere near good enough. And this has been proven multiple times to find early lung damage to the interstitium of the lung, which is what we're looking for here. What you need is a high resolution CT scan. Now, is a high resolution computed tomography scan perfect? No, but it is by far the best we have. Yeah, it's the only test that's sensitive enough to detect this early damage. So what do we do once we see it, right? Once we see it, because this damage does not yell to us and say, I am from scleroderma, right? Well, we can see the answer to yes damage or no damage. We can see perhaps what kind of pattern that damage has. Is it pattern A or pattern B or C or Z or D or F, right? But that doesn't tell us actually whether it's scleroderma, because scleroderma can cause multiple different patterns of damage. Yeah. So we've decided, okay, there's damage there. What's the next step? What do we do about that? Well, one of the next questions we oftentimes need to ask is this damage doing anything that matters to the person? So we have something called pulmonary function testing, which many of you will have experienced. Not fun to do early in the morning. They're much harder than most people think they are before you get to them, even for a healthy person. These tests help tell us whether the damage that we see on a CT scan has actually lowered lung function or not. They're very sensitive. You can have a good day or a bad day, and it may have nothing to do with your lung damage. It may just be that day is a good day and that day is a bad day. And that's because just like running a 100-meter dash, some days you had your breakfast and your coffee, and other days you were up in the middle of the night having to pee, and you're just not ready to get up and go in that day, right? So they're very sensitive, but they're not very specific. So they're good once we know what's going on. They're really, really, really good for tracking what's happening over time. And in fact, they're better for tracking what's happening over time than CT scans. CT scans are very sensitive, but they're hard to tell the differences when the differences are very small. Yeah. Pulmonary function tests use almost hyper aware to the differences. Yeah. And of the patients who have lung damage in their interstitium from scleroderma, which, as I said on the previous slide, was about 75% if you scan everybody, yeah, that has a scleroderma type issue. Only about 30 to 40% of those patients will actually progress in a way that matters. What's the difference between a way that matters and a way that doesn't matter? Well, if somebody is 80 years old and we're talking about losing 0.001% of your lung a year, something else is going to get you before the lung damage gets you, right? So that's not what we would call meaningful progression. Yeah, and it doesn't make sense to stand on the hill and put you on a bunch of pills to stop something like that. Now, on the other hand, if we're talking about losing 10, 20, 30% of your lung or more, that's imminent danger. That's imminent danger to your life. And it's very worth doing something about it if we can, right? So Can we know? How do we know who is going to get worse and who isn't going to get worse? How do we make that decision? It's really hard. It's really difficult, and there's no one test that can tell us. And so what matters the most is not that we throw treatment on everybody willy-nilly without thinking about it, but rather that we watch. Everybody needs to be watched closely. And part of the challenge with this is that, as many of you have experienced in your personal courses of this, or the loved ones that have been associated with you that have had this or something like it, it's actually fairly rare, broadly speaking, right? And that means that even a pulmonologist that sees lung disease all day, they're not going to see a lot of this type of lung disease. And even a rheumatologist that might see rheumatologic disease all day, they may not see a lot of this particular thing. And that can get a little challenging, because if you don't see it over and over again, you're not really used to how aggressive one needs to be with the watching, right? How much benefit you get from having multiple people watching. One set of, if you want to watch something like a fire, make sure it doesn't burn down your house. Sure, you can sit there and stare at it all day, but it's far better to have a group of friends watching it, so that when inevitably one of you is going to get distracted and look off in one direction, right? And someone else's eyes are going to be on the thing at all times. The other challenge about this is that scleroderma is a body-wide disease, and there's no sclerodermatologist, right? There's no when doctors hundreds of years ago split up the human body into who was going to focus on what, right? We did not split this up in a way where we said one's going to focus on scleroderma. We said, okay, I've got the lungs, you've got the toes, you've got the eyes, right? But the problem is we're dealing with issues now that we better understand, and these issues affect the entire body. And so someone who's just starting from the perspective of one organ, they're a little bit behind the 8 ball, and they may not notice signs that might say to us, hey, this person may actually be getting worse. It may not be getting worse right here in the part that I pay attention to, but it may be getting worse somewhere else. And that may portend worsening other places. That may portend worsening in the lung. So the more people you have watching, and the more focused they are on these type of conditions, the more they see of it, the better chance that they're going to be able to answer this question in a way that means something to you. Okay. Now, something else that's worth talking about, just because of the sheer amount of harm we've seen these cause. There are other tests out there, other relevant tests. We've talked about CTs and pulmonary function tests, but there are relevant tests. There's blood work, of course, which you've all experienced, and that is really important, but it's also not dangerous most of the time. If you have somebody who's good at drawing your blood, I suppose it can be very unpleasant if it's not. There's also things like bronchoscopies, which are like a colonoscopy, but for your lungs, I promise. It's a different scope that the pulmonologists use. It isn't usually that useful in this condition, but it also is a very safe thing. Very unlikely to end up causing harm. So we don't use them a lot in this condition. We use them sometimes if they're necessary, but unlikely to cause harm. The thing that I focus on, and we have a slide about here, is a surgical lung biopsy, which is something that's very different. Surgical lung biopsy is when a group of cardiothoracic surgeons will cut through the outside of your chest wall. I suppose you can't see what I'm doing here, but I'm drawing a little line on myself because I like to be active when I'm speaking. You're cutting yourself on the chest wall, you're going in there and you're taking a piece with a small knife or something similar of the lung out to look at under a microscope. All right. That's not really useful in this type of condition. The only time that's useful is if someone is really, really concerned about infection or cancer. If you're not concerned about those two things, there's almost zero cases where that's necessary. Okay, sure, yes, that procedure can have more complications. Yes, you can have nerve damage from having the cut. But the big issue here is that for patients with autoimmune disease and like scleroderma, doing something like this can actually make the disease worse, can actually make your immune system damage your lung worse. Yeah. So not only is this end up being useless, it can end up being dangerous and in some unfortunate cases actually fatal, even though it doesn't happen right away. 4 months later, the flare of the disease ends up causing the loss of some life. And the reason for this is when you get a cut, just like on your finger, your immune system gets activated. It gets called to that place to heal the damage. And if the immune system is what's causing the damage in the first place, that is not a good situation. You don't want to call in the opposing army. You want to use your own. You don't want to do that. So surgical biopsies are more likely to cause harm than help in most scleroderma cases. Now, why does catching this early make so much of a difference? And why do we have to spend so much time thinking about, is this person really getting worse in a way that's going to matter or not? Well, that's because there's no treatment, device, or exercise that can reverse or heal lung damage, lung scar, once it's formed. There's nothing. We've got nothing. There's nothing in the pipeline that's coming for that. No one can even do that on skin, much less in the lung. So the best case scenario for treatment is halting progression of the damage. It's doing what we did in that diagram, right? Getting back up there and yoinking the scleroderma off so it stops pushing on that rock. But that doesn't do anything about the rocks that scleroderma already pushed down the hill. Once the rock gets pushed down that hill, you're really not going to stop it. The best you could do is slow it down for a second as the rock runs over you, right? So this means if we're really trying to preserve lung, and by doing so preserve life, we want to get it before it goes over. There are two, generalized speaking, targets for treatment. And I don't mean to say that the name of the small target, I talk about general purposes, right? The most important target by far is the immune system. And this is what maybe other physicians that don't spend a lot of time with these conditions maybe gets lost in the noise a little bit. This is the priority. In fact, this should be the only priority, because in scleroderma, we know what the cause of the damage is. We know what's pushing the rock. And if we can stop that, we can stop the damage progression because nothing's pushing the rock over anymore. Yeah. This is alternatively referred to as immunosuppression or immunomodulation. There's many different drugs that exist for this. We'll get to those in just a moment. But the second sort of broad form thing, which has gotten more press recently, because it's making a couple companies, they've got some new things out there for this, are targeting the scar forming cells. This is equivalent to standing at the bottom of the mountain, or if I'm being charitable to them, standing in the middle of the mountain. Okay. The best that is ever going to do is slow something down. It's not going to slow it down by much. And it absolutely should not, you should not spend any time on that if you haven't already spent a ton of time trying to stop it back up before you pushed the rock in the first place. Okay. So regarding immunomodulation, there are multiple options: prednisone, mycophenolate, cyclophosphamide, azathioprine, rituximab, many more. We could just keep going, right? These things have been looked at in trials, and we could dig into the trials specifically, but I don't actually think that's the most useful thing that I could be talking with you about. And the reason for that is these options are not equal, and they're actually pretty complicated in terms of what they cause. The pluses, the minuses, why you would start with one, not start with the other. And most pulmonologists have very little experience, or not even have privileges, frankly, and have never written for some of these medications and their differences. And so when that happens, they end up falling back on just the few that they know about, or the few that they're comfortable prescribing. And that is not sufficient in this, because oftentimes the ones that they are comfortable prescribing are not the ones that are the best options to begin with. Yeah. So it's crucial that pulmonologists and rheumatologists communicate, right? And sometimes even more ologists. Like I said, you add up all the ologists that you need because we're taking care of the whole body. We're taking care of the whole patient. We're not just getting locked off in our own little kingdoms. Yeah. So of these, just to share this one piece of information, mycophenolate, which is also called Cellcept, is often the best balance between effectiveness and side effects as the first go. But we don't have a way of predicting who that's going to be the best one for and who it isn't going to be. So generally speaking, this is the best first start, but it's not going to be the best first start for everybody. And many patients, it's not going to be sufficient. So we'd start something like that, and then it won't be enough for the next. So we'll have to swap until we find something that works. So multiple things may have to be tried. That doesn't mean that immunomodulation isn't working. And I've heard many times, I'm sure you may have run into this yourselves, someone will start something and go, well, this medicine isn't working, but let's stay on it and add something different. That's not the way to proceed. The way to proceed is, this one isn't working, let's stop it. Let's switch to something different that might work instead. If you just end up stacking things and stacking things, or end up admitting defeat and saying, well, this one isn't working, I don't have much else, you're not doing right by the patients. You're not doing right by what we know about these medicines. Yeah. Coming to the other group, the anti-scarring medications, they are not as successful as immunomodulation. There are two options out there, nintedanib and pirfenidone. Ofev and Esbriet. Ofev and nintedanib have gotten more press for this, like scleroderma, because there was a recent couple trials that looked at this. They can be appropriate to consider as additional treatments if immunomodulation isn't holding the line all by itself. Yeah, but they cannot replace it. They are not sufficient to do it by itself. And frankly, they will never stop anything. They're standing in the middle of that hill, right? Or at the bottom, if you're being uncharitable with them. The best they're going to do is slow it down just a little bit. They're never really going to halt it. All right, move forward too quick. What about other things? Just to close this out. Well, all of the other things that can get done here don't really focus on slowing down the damage. They focus on bolstering the rest of your body. Because if you think about this, when you take tissue damage, this is you lost your left foot. Someone who loses their left foot, but they were a marathoner and they've got really strong legs and they're really, really aerobically conditioned, right? They're going to do way better with that loss of foot than someone who isn't any of those things and doesn't walk very much and spends most of their time sitting. And it's similar with lung. If you're going to take a loss of lung damage or loss of lung tissue, 30%, 40%, or 50%, the rest of your lung, the lung that is not damaged, is going to have to carry that the extra weight for you. And the healthier it is, the happier it is, the better you're going to carry that extra weight. In a situation in which you don't feel good, and the more that you do something, the worse you feel, that's scary. You're dealing with something with that. That doesn't make you want to do more if you don't feel good when you do something. So then you avoid activity. It gets worse because now the part of your lung that was healthy is not conditioned as well anymore. And it creates this nasty spiral. And so what we talk about with some of these other things, they're pushing back against that. They're helping you stay in the green. They're helping you stay in this green, which is decreasing your symptoms, helping you understand your symptoms, helping you focus on what can make you feel better and keep the rest of your body strong so it can carry the weight of this damage that's been sustained from the issue. And that's bringing to a close my portion here. I'll say that at the Interstitial Lung Disease Clinic at OHSU, we do bring together a number of different physicians that don't just talk to each other via email. We see each other every week. We talk about the cases every week, every day, sometimes even, because we're trying to be better, be better than just doctors that are focused on their one organ. And if you don't have a center like that near you, it makes sense to facilitate the communication because that's crucial. And so moving on to the colleague that I communicate with very frequently, this is Dr. Jeff Robinson, and I will turn it over to him.
Thank you, Daniel. Yeah, thanks for having me, you guys. It's nice to see some familiar faces and some new faces out there. And so I'm going to shift focus just a little bit and talk about how scleroderma affects a different part of the lung here. This is a sort of a cast of the lung. So this part here on the left is a cast of all the airways. And then on the other side, they still have the airways, but they've put in casts of the pulmonary venous and arterial system. So all those fine little blood vessels that run along those tiny little air sacs. And stealing Dan's illustration earlier, what we're talking about here, so he was talking about a thickening. If we zoom way in, there was a thickening of the wall here. We're really focused on these fine, small little blood vessels that sort of accepts that oxygen that's being diffused through, and that the blood cells get oxygenated. And what we see in pulmonary hypertension, which we'll talk a bit more about in a second, sort of the definitions of that. But what we see are that in some individuals with scleroderma, and there are many other causes of this as well, but these blood vessels, rather than being wide open with smooth blood flow through them, the vessels themselves start to get diseased, and they start to get almost occluded by abnormal cells and little blood clots. And it really impedes that smooth blood flow that you should have through those tiny, tiny little blood vessels. And so what is pulmonary hypertension when we talk about it? It's subtle. So if you think about your normal blood pressure, we put a cuff on your arm, and we think about a normal blood pressure as being somewhere around 120/80. So an average pressure of 100 millimeters of mercury. And the lungs are vastly different. The average pressure, if I had a little cuff just for those vessels in the lungs, the average pressure would be something more like 12 or 14, much, much, much lower. And that's because there are so many vessels. If you think back to that first image I showed you, if you take out all those blood vessels in the lung and spread them out, they cover about half a tennis court. And because there's so many pipes, it's a very low resistance system with a very low pressure. In pulmonary hypertension, because those vessels start to get diseased, stiff, occluded, we see that pressure start to rise up. And whereas normal is something like 12 or 14 millimeters of mercury, abnormal is anything greater than 20 millimeters of mercury. And what does this do? Why is this problematic? You can think about the heart and lungs as a circuit. They're all literally connected together. And so this is sort of a normal appearing heart. And what we're going to do is sort of splice it apart. That way we can try and understand this better. So it's the right side of the heart that's here. The right side of the heart accepts blood back so it accepts blood back from the body that's not carrying much oxygen. It goes through this right side of the heart into the pulmonary arterial system. And it's these small vessels here in the middle that are abnormal in pulmonary hypertension. And that blood then returns through the lungs to the left side of the heart, which is then ejected to the rest of the body. So this is the very high pressure system. It's used to seeing that pressure of 120/80. Well, this side is used to seeing a pressure, again, 12, 14. It's very, very low pressure. And so when these vessels start to get occluded, you can think about it, this is kind of like a pump or like a motor. And as that pressure starts to go up, this motor is used to seeing a pressure of 12 or 14. And as it climbs higher and higher, this side of the heart can really start to struggle. It gets bogged down. And ultimately, it can lead to heart failure, which is kind of the worst case scenario for a patient with pulmonary arterial hypertension. Again, this happens for many different reasons, but people who live with systemic sclerosis is one of the few groups that we know are at risk for it. And I always say systemic sclerosis never reads the textbook, but there are some general rules that may put you at higher risk. The longer that you live with systemic sclerosis, it does increase your risk for developing this high pressure in your lungs. There are certain lab tests, certain antibody profiles that may put you at higher risk of developing pulmonary hypertension, antisentamine antibodies being one, but that rule does not hold true all the time. So we're careful about screening everybody with this. Additionally, this can be seen in all forms, diffuse, more limited disease. Again, it can be found in all forms of systemic sclerosis. And in total, we estimate that about 10 to 15% of people who live with systemic sclerosis may develop pulmonary arterial hypertension. It can be hard to detect, and it's because the symptoms are not very specific. The major symptoms that we see in early pulmonary hypertension are shortness of breath and fatigue. And there are so many different things that can trigger this. As the disease gets worse, we see more obvious signs like lower extremity swelling. People can have palpitations, chest pain, things like that. And lightheadedness, fainting is a very concerning sign within people who have very severe pulmonary hypertension. Because these symptoms are so nonspecific, there could be a lot of delay. People oftentimes may be misdiagnosed as asthma, other diseases that may cause these kind of vague symptoms. And to this day, it's still, on average, it takes people about 14 months to get the correct diagnosis from when they first get those symptoms. And so it means about 3/4 of our patients are really at a very advanced stage of disease, meaning they're very short of breath with really minimal activity by the time we meet them and actually confirm a diagnosis. Again, this is sort of an all comers with pulmonary hypertension. And this is where, as much as I hate systemic sclerosis, maybe the one good thing about it is that we know the risk for this. And so we can screen it to try and catch it much earlier than we do in the average person. So again, this outcomes are much better when we catch it early. And so we're big proponents in our clinic that patients with systemic sclerosis really need to be assessed annually. So even if you're asymptomatic and don't have any signs of this, we really want to track closely to make sure that you're not developing it, to try and catch it as early as humanly possible. When we're evaluating for the presence of pulmonary hypertension, there's a lot of tests that are done because we want to, again, there are many different things that can trigger high pressure in the lungs, and we don't want to just assume that it's your scleroderma. So in general, if we have concerns that there may be high pressure in the lungs, we're oftentimes doing a CT scan. We're looking for the presence of interstitial lung disease, like Daniel was talking about. We're looking for the presence of other heart disease as well. One of the really good screening tests that we do is an echocardiogram. An echocardiogram, we can't diagnose pulmonary hypertension, but we can see definite hints if it's present. And so this is sort of our favorite screening tool. It's nice because it's non-invasive, and it only takes usually about 45 minutes to an hour. And it gives us ultrasound images of the heart. We can actually visually see how the heart is working. If that right side of the heart is under any strain, sort of showing that that motor is running down from the high pressure. And it gives us estimates of the pulmonary artery pressure. But it's important to know that those are fairly inaccurate. About half the time, they're either way over or underestimated. So it's a flip of the coin how accurate those are. That's why we can't use this to truly diagnose it. It's an estimate because we use Doppler radar for that. And Doppler radar is not very good for predicting the weather. And it's even worse when you're trying to do an ultrasound through skin and muscle, breast tissue, and finally getting to that heart, it can be rather inaccurate. But again, it can give us really good hints and push us to do a more definitive diagnostic test. And that definitive diagnostic test is something called a right heart catheterization. This sounds worse than what it really is. I hope that those of you that have been through this can attest to that. But in general, we numb up the neck, sometimes your arm, and in a very thin catheter, seen here, this little yellow catheter is an example of one of the ones that we use, but through an IV, we insert that into a vein, and we're able to actually directly measure. This is sort of like our blood pressure cuff for the lungs. And so we're able to measure that pressure directly. We're able to measure flow through the heart. And we also do special testing during this at OHSU to really help determine what, if you do have pulmonary hypertension, what treatments you may respond best to. And in general, it's pretty short. It takes usually about 20 or 30 minutes, and you go home the same day with a Band-Aid on your neck. And sometimes when we do heart catheterizations, we're relieved. We find that there's not pulmonary hypertension, which is great. But then we have to still explain your symptoms because there are other things that can occur to the heart in systemic sclerosis. So during that heart catheterization, sometimes we're able to detect other things that we see that scleroderma can do to the heart. And one of the big ones that scleroderma can do, that left side, that big strong side of the heart, that's scleroderma can actually cause some fibrosis, just like it causes fibrosis in some of your skin. It can cause fibrosis of that ventricle and make it very stiff and make it hard to fill with blood. We can see signs of that when we're doing this heart catheterization. Sometimes we can pick up signs that the left-sided pump is not working well in and of itself. And so it can be a useful test to delineate between multiple different things that can occur to the heart in systemic sclerosis. If we do find pulmonary hypertension, if this is one of those things where if you Google pulmonary hypertension, you read all these dire things because most of it is outdated. Pulmonary hypertension is a serious thing, but outcomes have really improved in the last 20 years or so. And that's because we've had a really rapid development of multiple different options to treat this. A lot of the bad statistics of people having very short lifespans with this disease actually come before 1995. And 1995 was when we had the release of the first drug that really targeted those vessels in the lungs and helped us treat this disease. And since that time, we now have 14 FDA approved therapies, which in our world of medicine, that's really a quick revolution to have so many options to help people with pulmonary hypertension. And so we have all these different options, and the specifics aren't too important, but The critical thing is, so these 14 drugs, sort of each of them targets one of three main pathways. And there are these three different pathways that we kind of target to try and sort of relax those vessels in the lungs, open up those vessels and release all that pressure on the heart. And in turn, what that does for people is help them walk further, do more, feel better. And it's really helped people live much longer. And so we use a combination of those 14 drugs to target each of these pathways. So for most of my patients, I'm targeting at least two of these pathways. Again, it's sort of taking a multi-pronged approach, trying to hit every aspect of this disease to slow it down and make people better. So 5 main things to take away that you should know about pulmonary arterial hypertension. This comes in many different forms, and really careful diagnostic testing has to be done to make sure that you have the pulmonary arterial hypertension that we see with scleroderma, rather than some of the other forms of heart and lung issues that can come from the disease. The longer that you have this, the higher the risk of getting pulmonary arterial hypertension. So having one echo 5 years ago that looked pretty good isn't enough. You got to keep getting screened for this. I'm a really strong believer that outcomes are always better if we diagnose this early. So even asymptomatic patients, I tend to continue to assess them annually pretty aggressively to try and find this. To diagnose it, we can't just use the echo, unfortunately. We have to use that right heart catheterization. It's really, really crucial to make sure that you're safe to start on those medications. And finally, there are many different treatments available. It's a new world treating this. And I'm also a strong proponent. This is a rare disease. In the general population, it's about 12 in a million get pulmonary hypertension. It's very rare. And so again, like some of the medications for the interstitial lung disease form, you really should be seen by someone with a lot of experience in treating pulmonary hypertension. The future, I'm kind of excited for the field of therapeutics in pulmonary hypertension, because I think we're on the verge of something new. There are innumerable trials going on now looking at really targeting the disease process itself. And we're actually doing trials in scleroderma itself, trying to target that inflammation that we see in it. And so sort of our holy grail is to be able to reverse all this damage that's done to the blood vessel. We don't have medications like that right now, but I'm hopeful that in the future we will, to really make a much, much bigger impact in this disease. And finally, echoing what Daniel was stressing, we are really strong proponents that this takes a huge team approach. I keep revising this illustration of the team that you need behind you, and I keep adding more and more circles. And I was starting to add more, and then I realized I was behind time. But we have rheumatologists, we have pulmonologists, cardiologists, radiologists. And this is sort of our core group that meets on a weekly basis to talk about patients and put our heads together, because it's very, very complex stuff. You could add to this gastroenterologists and so many other ologists. But and the other critical thing is you are the most important part of this team in advocating for yourself and making sure that you have a team behind you screening for all this stuff. So I'll stop there. Thank you guys for the invitation and attention. And I'm sure Daniel and I are happy to take any questions that you may have.
Feel free to write your questions in the chat box. Looks like we have about 10 minutes or so left. There's one. Can you see the chat? Or
Yeah, that one's for Jeff, sounds like.
Good. Yeah, so do we ever start treatment for pulmonary hypertension in asymptomatic patients? The great majority, I've actually never met a patient who has elevated pressures to the level where we would call it pulmonary arterial hypertension. They've had no symptoms at all. But yes, again, I think we have to treat early. And so if the heart catheterization confirmed abnormally high pressures, then I would advocate for treating that. The disease tends to progress with time, and so I think you have to hit it up front.
I'll move through some of these next ones. Janice, you'd asked, what is a radiologist? A radiologist is a physician that early on in their training started specializing in the reading of scans. So this is someone who spends pretty much all of their day looking at various types of imaging. And in this particular case, the ones that collaborate with us only spend their time looking at imaging of the chest. So this is even more hyper-specialized in terms of the area. Next, we had our scleroderma organ transplants at OHSU. So OHSU is not a lung transplant center. And lung transplant centers for scleroderma, it's a challenging thing because some centers consider that a contraindication, or in other words, something that they don't want to do a lung transplant in, because there are some situations in which the disease, the scleroderma, your immune system may attack the new organ as well. What we do at OHSU is work very aggressively against the immune system, perhaps more aggressively than some other centers. And because of that, when and if patients progress to the point of needing a lung transplant, and I think less of ours do than other places, we are very effectively able to work with other centers to get them where they need to go and make a convincing case that in these patients, the damage has been paused. Let's see, next one up here. Thank you, Allison. Let's see. So we've got Toby Solomon asking, short of breath for about 20 years, no doctor has found anything to cause this. Have I had echoes and stress tests and lung capacity tests? Is there anything else to request? Shortness of breath is a pretty broad thing, as I sort of mentioned when I was talking through, right? It's the baby crying, so to speak, and you don't know why. And so it can be really, really, really frustrating because shortness of breath can affect you in so many different ways to not know what it is or what's causing it. When all else has failed, there is a type of test that might give you some more general information. It's called a cardiopulmonary exercise test, or CPET, or CPEX for short. I'll put it in the chat so you can understand, because it's going to be difficult to CPET or CPEX. And actually, that is a type of test that can be run very differently depending on the center. At Oregon Health and Science University, the CPETs that are done on patients with issues like what you're describing are all done by me personally. And so we can get a little bit more in-depth information, and that might actually be a nice next step. CPETs are good at one thing in particular. While they can get you a bunch of answers, they really can tell you if something dangerous is going on. If a CPET comes back as totally normal, whatever it is that's causing the symptom, even though it might be miserable, it's very unlikely to take your life, which can be some sort of a balm, even in a situation where it's really uncomfortable. We've got flare of disease with lung biopsy. Can surgery in another part of the body flare the scleroderma and flare either? That's an interesting question about whether getting cut on in a different place can flare the lung damage. I don't think we know a perfect answer to that. I think the answer is much less likely than getting cut on in the lung. Yeah. But in patients with scleroderma in particular, when it's generalized, the skin is also a part of this, which is not always the case for every autoimmune disease. And because the skin is involved, very rare that you're going to find a surgery that doesn't go cutting through the skin in some way. So having damage to that portion of the skin very well may flare disease in that area. But no, we would not expect it to flare distal disease. There are other considerations in patients who have pulmonary arterial hypertension. Surgery can be a very challenging proposition if you're undergoing something like general anesthesia. And so what's key, again, is the collaboration between physicians. If you're someone who's been diagnosed with pulmonary arterial hypertension or interstitial lung disease, It's not a good idea to go to an outpatient surgery center where someone says, oh, no big deal, you know, let's go through with this. You really need to have your team involved and advising these physicians, these surgeons who may never, or anesthesiologists who may never have run into these issues, period. Let's see, Lee Doss, who is the scleroderma? That is me and others like me. So myself and one of the rheumatologists started this collaborative clinic back in 2017. And we have a number of others like Dr. Robinson, who's joined us and worked collaboratively with us. But if you get referred, I'll be the one that does the referral triage, and we'll either get you to see myself or one of my colleagues. And I'm aware of all of the cases here because we do discuss them on a weekly basis. And then let's see, are the lung involvement also cause problems for the vascular issues and more? How can this be controlled to reduce wounds and ulcers? Actually, Natasha, I think what you did a good job. Jeff, did you want to answer that? Yeah.
Yeah, so there is a link between you know, the abnormal vessels in the lungs, and as you probably all know, there's a lot of Raynaud's that we see as well, and other vascular issues in those that live with scleroderma. And it's interesting. A lot of my patients come back after I've started treating their pulmonary hypertension. It always hurts my feelings because they're actually far more thrilled that their Raynaud's is so much better because these medications affect the blood vessels everywhere. And so some of these agents can be used to help control the Raynaud's as well. I hope that answers.
Got about 4 or 5 more minutes here, and I'm happy to sit and wait because I know sometimes typing through on phones or tablets can be a challenge, but don't let that stop you. If you have a question, take your time and we will get to it.
Yeah, Tina. So if I have a patient whose pulmonary functions come back normal and the echo comes back normal, and the first thing is what symptoms are going on, because that can really help us determine next steps. But like Dr. Seifer was talking about, I'm a big fan of trying to provoke your symptoms and doing testing during that. So one way of doing that is a cardiopulmonary exercise test, where we put you on a bike and look at different measurements of how your heart and lungs are responding to exercise. Sometimes if we're trying to catch very early pulmonary hypertension, I will actually do a heart catheterization and exercise you, so have you pedal while we do that, and sort of try and recreate the physiology of what's making you feel that way. And so occasionally we have to do things like that to really investigate deeper.
The only thing I'll add to that, Tina, is that a CT scan would be part of that initial workup. And if that hadn't been done, a high resolution CT scan, it's certainly possible for an echocardiogram to be normal and pulmonary function test to be normal, and still have lung damage and still have issues. And so a CT scan is actually the fundamental one. That's the one that finds the thing in the first place when it comes to the lung damage. The pulmonary function tests are good at the next steps, but the CT scan is the first step. Diane Peters is asking about CellCept, which in particular is mycophenolate, which is one of the immunomodulating or immunosuppressing medicines I asked about, or that I mentioned. All of these medications, to one extent or another, what they're doing is they're pressing mute on a part of your immune system. And that's because the immune system is the source of the damage, right? In a perfect world, we'd be able to place a mute just on the one that was getting out of control in you, but we don't have something like that yet. I hope that we will within the next 10 or 15 years. But in lieu of that, what we've got are larger mute buttons, yeah? And the immune system has a lot of jobs in our body. And one of those jobs in our body is to protect against infection. And the other is to actually help us from developing cancers, yeah? And so I think the two most problematic potential, I hesitate to call them side effects though, because when I think about side effects, I think about something like you take a medicine to thin your blood, but it also causes you to have diarrhea, right? These actually aren't side effects, what I mentioned of these medicines. This is the effect of the medicine. We want it to mute your immune system, but there are downsides. There are downsides to muting your immune system, and that is that they make you more prone to infection and can make you more prone to the development of certain types of cancer. Now, while those things sound scary, right, we don't consider using these medications if the problem itself isn't scary, right? And what we know about scleroderma is that if you don't get in front of it, if you don't treat it, that damage occurs and is irreversible, and it will eventually get you. Yeah. So when we use these medicines, we're very careful to watch for extra types of infection. We're really careful to watch for these types of potential cancers that can show up. They're not common when used, right? These cancers that I mentioned in particular, they're very uncommon, in fact. The example that's good to keep in mind, right? And I'm making up these numbers on the top of my head, but let's say that someone said, well, CellCept quadruples your risk of cancer. Okay, but what if that starting risk of cancer was 1 in 100,000? Okay, so if it quadruples it, that's 4 in 100,000. That's a quadrupling, but it's still not a big enough number to make a difference in whether or not it's safe to use the medicine to protect against something that's much more dangerous. Let's see, any recommendations about COVID precautions in the present situation? Yeah, so that's a type of infection, right? And the types of things, especially those who are on immunosuppressants or modulants, or even who aren't and who have this type of damage in their lungs, you're going to be much more prone to taking more damage to your lungs from a virus. And they're one of the more dangerous things that can happen. Now, that said, it's not a death sentence to you if you get this. If you get a virus, it doesn't mean for sure you're going to die. It just means you're more likely to sustain serious damage than someone who didn't have these issues or wasn't on these medicines. So just being a little more careful, getting your vaccinations, right? Letting your team talk to you about what your risks are and making smart decisions, right? About what risks you're willing to take in order to live your life in a way that's happy, because there's no point to going on living your life and making it another 20 years if those 20 years are locked in the closet and you're miserable, right? So part of our job as your healthcare team is to help sort of sort through, you know, maybe if maybe going to a big concert with a bunch of people who can't be trusted, maybe that's not the best way unless it's your very favorite band, right? But having a dinner party full of people that you would tell you if they had symptoms and would not come, that's a different thing. Those are different risks, and one can be okay while the other one isn't. Let's see, low dose naltrexone. So low dose naltrexone is an interesting thing. It's not, the point of it is not to slow the direct source of this damage. It can be combined with other of these issues if indeed it ends up being indicated. That's a little bit of a longer question to answer though in its full form. But I'll have to say that just in the short way to answering it, no, it's not contraindicated with these other things, but it's perhaps not as widely indicated as people would think that it is. So different mouthpiece, the scleroderma is figuring. If pulmonary function tests can't be done, right? That doesn't mean we can't track the disease. It just means we have to be a little bit more, creative with how we do track disease. There are ways of doing that with things like walking tests, 6-minute walking tests. Not every pulmonary function test requires the mouthpiece to be used, which is also a separate thing. So there are answers to that if we're not able to track. Let's see, kidney issues, high blood pressure. Jeff, you want to take that one from Nancy?
Yeah. So again, I think even if your issues with scleroderma haven't focused on the heart and lungs much, again, these things can pop up. And so we're still advocates of continuing to get screened for those, even if you don't have symptoms. So that's just following up with your docs, making sure you're getting your PFTs, echocardiogram, and a CT scan if you haven't had one.
I saw one more.
Another
Deborah asking about University of Washington, right? Deborah, our wait times are not a year. They're on the short end of being a month or two at max. Not all the time. In the ideal world, you'd be able to see, or people would be able to get in to see both us and the rheumatologist on the same day. That's where it was before the pandemic. We're working to getting back to that. But the first appointment with one of our team members can oftentimes be scheduled within 2 months. All that one needs to sort of get worked up for that is a referral place that specifically says scleroderma lung damage. If that is said in a referral, it will come to me directly and we will take care of it.
Okay.
The cardio, Tina was saying, what he was saying there was a cardiopulmonary exercise test, a CPET or a CPEX. We typed that in the box up a little bit higher. So if you scroll back up in the chat, I will have mentioned it to a different person. Okay, we should probably let everybody go on with their programming, I believe. I'll just say thank you again for inviting us. It's really a pleasure to get to speak to you all, who, as Jeff said, are the most important team members of all of this. Please feel free again to reach out. The organizers, I'm sure, will be able to forward other questions along if you weren't able to get them to us in time for the end of this presentation.
Thank you so much, Dr. Seifer and Dr. Robinson. This was fantastic. Thank you for giving up part of your Saturday to come and speak to us. We really, really appreciate it.